Welcome to Clinical Rounds. I'm Dr. DeFabio. One of the topics I've been talking about for a while in my classes is a shoulder examination. How to examine the shoulder to differentially diagnose. Is it a joint issue? Is it a contractile problem with the tendon or the muscle? Is it a non-contractile issue with the capsule, the bursa, the ligaments? Is it a neurologic issue, or is it something that's unrelated to what we do in the office? So what we're going to do today is clinical rounds. We're going to start with orthopedic, chiropractic, neurologic, and the introduction to functional assessment of the shoulder. So we're going to evaluate the shoulder, and then we're also going to talk about the top exercises to prepare the shoulder for rehab, because they all revolve around scapular repositioning, or also called scapular spiraling. So let's get started. However, what are you going to need today? You're going to need a reflex hammer, you're going to need a Wartenberg pinwheel, and a piece of CLX band. So Mike, my assistants, Mike, get me that reflex hammer, Wartenberg pinwheel, and stretch band, and we'll get started, okay? Now, the first thing we do when we examine anything is we look at it. So great, I'll need these. Mike, say hi to everybody.
Hello.
Mike, do you mind taking your shirt off for me today? Always check your patients to make sure they're comfortable taking off their clothes. If not, you may need to give them a gown, or you may need to do other things. So, first things first is you inspect the shoulder. Look for, in this case, let's face the camera, Mike. We'll look for symmetry of the shoulders. We'll look to see if there's any dipping from old AC injuries. Check the sternoclavicular joint, the clavicle as well. Take a look at the head, the alignment through here, chest development. Overall symmetry is what we're looking at. Turn to the back, please. Same thing with the back. What do we want to look at? We want to look at posture and alignment. We want to look at the height of the shoulders. From rehab perspective or an injury perspective, we're really concerned about development of the shoulder muscles left to right and top to bottom. Are the overtraps overdeveloped relative to the mid and lower? Are the rhomboids properly developed? What about the erector spinae? All right. When we do some of the range of motion tests, I'll show you how we get some information from that. So you inspect it, look at it first. Discoloration, masses, rashes, etc., etc. Have a seat. If it's red, hot, and swollen, be cautious. All right. So after we inspect it, passive range of motion. Relax the arm and just check passive range of motion. I'm moving with this hand. I'm palpating with my other hand for integrity of movement. Any pain, any stiffness, how far does it go? Are there any blockages? External rotation, internal rotation at 90 degrees of abduction, right? At neutral, extension, flexion again, just all ranges of motion. How do they feel? Passive range of motion. He does nothing. From there, we're going to go to active range of motion. Stand, please. Because if it hurts and they actively use it, then you've already made it irritated, and then you try to do passive range of motion, you may not get a good idea of what's going on. So I'd like to stand in front of the patient, so I'll excuse my back. Both arms at the same time, bring them straight forward. And how does that feel? Pain, stiffness, weakness? No. And you look for symmetry of motion. Really watch to see if you're getting jacking up and elevating of one shoulder. Straight out to the side. Pain, weakness, stiffness. How high can you go? Great. And down. A little bit of tightness on that side. At just the right side, at what point did you feel the tightness? Tell me. Just the right.
Right there.
Right there. So that's our marker. That's what we look for. Relax. Now let's have him externally rotate. Get the humeral head out of the way. And just the left, bring it up. How does that feel? Same, different, better, worse?
Much better.
Much better, because we took the humeral head out of the way. So we're suspicious that there might be some irritation to the supraspinatus, or in that critical zone where the humeral head is supposed to rotate away from the tendon underneath the AC joint. So bring your arms up 90 degrees, great. And then back hostage position, turn out, turn down, good, relax from here, great, turn out, turn in, good. Hands behind your head, push back, modified Apley's test, relax. A full Apley's test is reach all the way over this way, great. So if they can do hands behind your head and push back. You don't have to do the specific applies. Other part of applies, reach over, elbow down. Good. Reach over the other side. Good. Let's go back to the right. Now drive your elbow up. That's a nice indication of impingement, okay? It's not an official impingement test, but it's a nice indication. So, and just reaching straight back, and then behind your back, all right? And then around the other way. Pain, stiffness, weakness, asymmetry. We did active range of motion. We also did Apley's tests in their major motion, looking for dysfunction. Have a seat. That's active range of motion. Active range of motion is going to involve the myotendinous unit. If you get a painful arc, oh, it hurts there, and you keep going higher and it goes away, you're thinking there's a tendinitis or a tendinosis. You get a pain with active range of motion and it gets worse, you're thinking non-contractile or something with the joint, okay? Or you're getting pain and it just won't go further. That could be muscular weakness, could be joint locking, could be a non-contractile issue. So let's break it down a little bit more and we'll check resisted motor strength. So we're going to bring them up to here and I'm going to push down, hold, check flexion. Primary flexor is the coracobrachialis, but you're also going to get some anterior delt. Inscaption, so the humerus is in line with the scapula. We're going to check abduction, push up to the ceiling, supraspinatus. Other fibers of the supraspinatus, thumb up position, hold, thumb down position, hold, okay? Still inscaption. Now, if we're getting a little bit of pain with this, we're thinking, okay, there could be a contractile issue, tendon or muscle, especially if, relax, abduction's not a problem. Well, that's really good, but I bring you here and I resist and it bothers you, great. Then leaning more towards the tendon and the muscle as opposed to a ligament capsular joint issue. Inscaption as well, you're going to externally rotate, turn up, and then you're going to turn down. Okay? So we had our external rotators, teres minor and infraspinatus, internal rotators, subscap. Then we bring them down to neutral, push straight back, extension, posterior delt, a little bit of lat, push, pull forward again, true flexion from down there. Okay? Looking for pain, weakness, discomfort, and then external rotation from neutral, turn out, and then external rotation, internal rotation, pull in. According to the Goodhart and the AK people, this is more teres major, okay? As opposed to subscap, because it's medially rotating the humerus at neutral. So technically not a shoulder exercise, that's a humeral exercise, all right? Basic muscles, all right? From there, gotta check joint play, okay? Of the spine, see if anything's restricted, motion palpate the spine, through the cervical spine, occiput, very important that you address that. Really the topic of another video. Drop the chin forward, real important, you check for doorbell sign, anterior scalene, middle scalene tightness. By palpating the scalenes, if it shoots pain into the shoulder or down the arm, we know we have dysfunction in the front here, and they may need an anterior cervical adjustment as well as some myofascial release in through there. Remember we talked about you need a few tools now. Reflex hammer, check the biceps, check the brachioradialis, triceps reflex. Let's use my back again. Biceps, boom, boom, check those. You can also do a tap here, just to see if you're getting a hyperreflexia on the, cool. You can see he's got that reflex reaction, that's pretty neat. We tap here and the other side reflexively attracts, so that's, you can see a nice response there. Motor strength, and then lastly, sensation. All right, same or different? Here versus here. Same or different, you gotta check your dermatomes. Just let the pinwheel roll down. Radial nerve distribution. Ulnar, palm up. And then through here, and through here, and then over here. Make sure you're checking all the distributions. You're just asking same or different left and right. Palm up again. Tinel sign over the median nerve at the pronator teres. and at the carpal tunnel, check for that as well, all right? Remember, you can get referred pain anywhere in the shoulder. Left side could be heart, infraspinatus muscle, your scalenes, lots of referral pain points. Remember your trigger points. Next, you gotta remember to check for joint play. So Mike, line your back up top, please.
Thank you.
Yeah, that'd be great. So what we're gonna do is we're gonna check for joint play in the shoulder, okay? Bring the shoulder. Also, other really cool orthopedic tests from this position are your apprehension test in through here, all right? And then there's other orthopedic tests we'll do when we stand them up, okay? But supine, that's a really great test. You're gonna grab underneath the humerus, bring forward, and just check lateral glide, pushing straight out. I'm pushing my right hand, pushing out. We're gonna test posterior shear of the humerus at 10 degrees. Posterior shear of the humeral head and the glenoid fossa at 90 degrees, okay? Then we're gonna check lateral shear, but I'm using my shoulders, some leverage, lateral, and then down. And then we're gonna do a little scoop, go lateral and scoop as like a J motion, inferior scoop, okay? Those are the motions of the glenohumeral joint for joint play, see if they need adjusted. Then you need to palpate the AC joint, just in neutral. You can also bring the hand up all the way over the top and challenge it inferior, all right? You're gonna just sit back up for me over here, Mike. While we're finishing the joint, we're gonna check the sternoclavicular joint. I'm gonna palpate it here, bring it up to abduction. I should feel a little motion, and then rotate. I should feel a little rotation in there as well. So we check the AC joint, glenohumeral joint, sternoclavicular joint for joint locking to see if they need adjustments. Make sure you palpate the subclavius and the pec minor as well, because they can lock it up. However, it's not a true joint, but it's a very important joint. Part of the shoulder complex is scapulothoracic joint and scapulothoracic rhythm. So stand, turn your back to the camera, please, Mike. We're going to look at how the scapula, here's the inferior angle of the scapula, the inferior angle of the scapula, here's the superior angle of the scapula, here's the superior angle of the scapula. We're going to look at the motion of that when he moves. So let's go straight into abduction, real slow, reach out, and just see how they move relative. Watch the motion here and go all the way up, okay? First 30 degrees should be humeral motion, then up to 90 degrees, it should be a little, scapula should kick in, and by here it's 2-to-1 humeral to scapular motion. And it should be symmetrical. This should angle, the inferior angle of the scapula should come about to the mid-axillary line. Come on up. And boom, there's his now his inferior angle of scapula is now here, mid-axillary line. That's what we want to see. Relax. I also have them do it going straight forward, reach straight forward to make sure we're not getting any winging through here and we're getting symmetry of motions. Let's come back, go out to 90 degrees, just hold your arms. That's the position you want to check for symmetry of movement, okay? To see if, symmetry of muscle strength. Of the rhomboids, of the upper traps, levator scap, even through your erectors. That's a good way to see if the athlete, your patient's been training evenly. Relax. Last test is to push against my hand or against the wall, check for winging of the scapula as well. Serratus anterior weakness, all right? The top exercises to treat this for everybody is going to be scapular repression and retraction, getting down here, okay, and getting those external rotators firing. So you got it, we can do that. Where's our band, Mike? Here it is. Burgers is a good place to start. If the patient can tolerate it, pinching, retracting, and then rotating out. A nice way to engage those muscles without firing the anterior shoulder is go on your side with a small weight. There we go. Got one there. Or you can do it with a stretch band. Can't go wrong with the CLX bands. With a small weight, external rotate, keeping the elbow pinned in. All right. And if they're really acute, lie over onto your stomach, let me have the weight. And they're really having problems just moving the arm in general, non-weight bearing, let the arm hang over the shoulder, over the table, and just try plain old flexion. It's a nice way to engage the posterior chain without aggravating the anterior chain. All right? It's been a great day to talk rehab. Thanks for tuning in. Clinical rounds on the shoulder. Next one is going to be about functional assessment and continued rehab. Thanks for tuning in.